Good afternoon and welcome to this Australian Centre for Value-Based Healthcare webinar. Where are they now? Value-Based Healthcare Award winners 2021. I'm Deb Cole, the Chair of the Australian Centre for Value-Based Healthcare, and I'm joining you from the land of the Wurundjeri people, the Kulin Nation, and pay my respects to their elders past, present and emerging. I would like to acknowledge and pay respects to the traditional owners of the many lands of which we all come from and recognise their continuing connection to land, water and culture. In late October, the Australian Centre for Value-Based Healthcare will announce the winners of the 2023 Value-Based Healthcare Awards at the Value-Based Healthcare Congress in Brisbane. These awards are designed to highlight the outstanding work of health services, individuals and systems in transforming healthcare for person-centred, outcome-focused and value-based healthcare. And there is a lot of great work happening in value-based healthcare space around Australia. And yet the message we continually hear from people that are trying to embed value-based healthcare is, I don't know what I'm doing and where to from here. So today we thought it would be really timely to revisit some of the previous award-winning projects to see the progress that's been made and understand the barriers and enablers that have impacted implementation. And while you've all seen everybody's CVs that have come out with the program, but you're going to hear from Melanie from Dental Health Services, Victoria's Smile Squad School Dental Program, the winner of the 2021 Innovation Award, Shireen and George from New South Wales Health, who will talk about the 2021 finalist project Integrated Care Implementation of Planned Care for Better Health, and also the strategic evolution of value-based healthcare within New South Wales Health. And then Anna from the Sydney Local Health District Osteoarthritis Chronic Care Program, the winner of the 2021 Collaboration Award. And so before we start finding out a bit about the projects, I'm just going to ask each of them to share just a couple of sentences about their background. So Melanie, can we start with you, please?
Thanks, Deb. So my name is Melanie Van Altena and I'm the Program Director for the Smile Squad School Dental Program. I've held senior roles at Dental Health Services Victoria for the past 10 years and I've been with Smile Squad since 2019. Began my career as a physiotherapist working in public and private sector in Australia and the UK, and I have a 20+ year career in healthcare as well as working at Transport Accident Commission and Comcare.
Thanks. Shireen, would you like to go next, please?
Thank you, Deb. Hi, everyone. My name is Shireen Martin. I'm the Director of Connected Care and Partnerships here at the Ministry. That includes 3 programs in my portfolio: Integrated Care, Collaborative Commissioning and Leading Better Value Care. I have many years of experience as an emergency department clinician, nursing unit manager and hospital operations. And I've been at the Ministry for the past 13 years in a range of different roles. But I think I've finally found my passion.
That's what we like to hear. And George, would you like to introduce yourself, please?
Sure. Hi, Deb. Hi, everyone. My name's George Lapnick. I'm the Director of Strategy and System Priorities at the New South Wales Ministry of Health. Like Shireen, I've worked in a range of roles, although I haven't had the pleasure of working in the EDs. My background is in economics, service planning, and most recently, my team has been leading the value-based healthcare strategy and the future health strategy for New South Wales Health. So really that is about bringing together the range of work across the system and how we communicate it out in a coordinated way to all our staff and stakeholders.
Thank you. And now Anna.
Thanks, Deb. I'm Anna Ananda. I'm Head of Rheumatology at Concord Hospital and Senior Staff Specialist, and I've been a clinician for more than 20 years. My PhD was in osteoarthritis, and so I was the lead in developing the Osteoarthritis Chronic Care Program at Concord as the start of the program for the district, and I'm excited to share our learnings.
Thank you, everybody, for that. Now, what we want to do is to get a bit of an understanding of each of the projects, and I'm going to ask each person to speak about it. But what I would like to remind all the people listening in is that throughout the session, there's a Q&A function at the bottom of your screen. and I'll get you to send any questions you like through that, and then we'll have an opportunity again to ask questions. So I'm going to start with Melanie first. I would like, if possible, you could tell us a bit about the Smile Squad dental program. And I think Melanie has a few slides she's going to show as well.
I have got a couple of pictures. Thanks, Deb. So we can probably go on to the next slide, if that's all right. So Smile Squad's come a long way since we won the award a couple of years ago. As of the start of this year, we're now offering free dental care to all Victorian government school students. For those of you who don't know about Smile Squad, I'll just give you a bit of a background. Smile Squad is the Victorian government's free school dental program. It provides all Victorian government primary and secondary school students with free, high-quality dental care, saving families valuable time and money. So that's more than 650,000 students at more than 1,500 schools across the state. DHSB is responsible for leading and managing Smile Squad service delivery through partnerships with community dental agencies across the state. Continued program development is being led by DHSB and the Department of Health in partnership with the Department of Education. In exciting news, in 2022, the Smile Squad was able to offer unrestricted service delivery across the state for the first time in more than 2 years. In August 22, the Victorian Government announced the establishment of 3 regional hubs in Bendigo, Geelong and the Latrobe Valley regions, enabling children in regional Victoria to access specialist dental care close to home. These hubs will offer a range of specialised dental care for children in all specialist disciplines except for orthodontic treatment. Children can be referred to these new services through the Smile Squad program. Also in 22, the Victorian Government confirmed its commitment to the Smile Squad program by announcing it will be expanded to low-fee Catholic and independent schools from 2026. Smile Squad provides a unique opportunity to reduce the burden of oral disease across Victoria, supporting students to enjoy the benefits of good oral health. Smile Squad believes children and young people should be free to learn and play without dental disease negatively impacting their eating, sleeping, or their ability to concentrate. With a strong focus on education and prevention, Smile Squad empowers students with the tools and knowledge they need to eat well, drink well, and clean well for life. DHSB was an early adopter in integrating the principles of value-based healthcare. These principles guide us in creating an integrated oral health service that's focused on improving the health outcomes that matter to patients in a cost-efficient way. I'll take you back now to our original program design that shows our framework for implementation and talk you through some of the many things we've learned along the way. The Smile Squad program has been planned and implemented in line with the DHSB value-based healthcare framework that you can see here. Put simply, the Smile Squad framework is a person-centred system based on what students need. It provides the right services by the right person at the right time in the right locations, achieves the best outcomes at the lowest cost, integrates care across separate facilities, and measures outcomes and costs for all clients. We put the consumer and the workforce at the centre of our framework, and we take a population-based approach to providing services. We did start off with a pretty rigid service delivery model. Smile Squad was originally set up to deliver services only in schools during school hours, but it turned out this wasn't the only right location or the only right time. Families told us they wanted more flexibility, and some family members want to be able to attend their child's appointment. We've faced some challenges getting into schools as well, availability of an appropriate space and infrastructure, conflicting priorities for schools and time. So that's why we keep revisiting our model and looking at how we can better hone what we're delivering and how we're delivering it. We've trialled larger multi-chair setups and assessed different vehicle types. Students eligible for Smile Squad can also now walk into their community dental clinic and be seen outside of the school environment and hours if that suits them better. None of this would have been possible without taking a collaborative approach to service delivery. DHSB's had the task of onboarding agencies to the program across the state. When we launched the program in 2019, this was done following lengthy consultation and collaboration with experts at other agencies. The proof of concept saw us work closely with 4 agencies to test the program in the field and to improve it based on their experience and findings. And we continue to take this collaborative approach. Smile Squad has a number of formal governance groups as well as informal groups that help to inform the program's future. All Smile Squad agencies are invited to a monthly community of practice meeting to discuss the program and to raise any issues, concerns, or to discuss areas for improvement. We recruit agency representatives to all of our key working groups and projects to ensure their views are represented and expertise utilised and learnt from. Smile Squad has a strong emphasis on preventive care and is firmly rooted in the practice of minimally invasive dentistry. The Smile Squad care pathways determine the way we treat students enrolled in the school dental program. Students are segmented into those who need active care and those who only need supportive care. The care pathways remain largely unchanged, but they undergo regular review to ensure that they remain evidence-based and that we provide the right service by the right person at the right time. In 2022, we developed and delivered the Smile Squad electronic consent form, making providing consent for services easier for families, as well as easing the administrative burden for agencies. A happy and fulfilled workforce only serves to strengthen a program like Smile Squad, but what if you're having trouble employing enough people to deliver it? That's a challenge that we're continuing to work through. DHSB has supported agencies to recruit to Smile Squad positions and created its own regional teams across the state. We've currently got 4 regional service delivery teams that are focusing on supervising and coordinating student clinical placements, supporting agencies to provide services as efficiently and effectively as possible, and servicing small schools predominantly in the remote areas. Partnering with the Melbourne Dental School at the University of Melbourne, La Trobe University and Holmes Glen Charles Sturt University, Smile Squad also offers clinical placements to eligible students, providing them with a practical on-the-job learning opportunity under the expert supervision of qualified clinicians. Many of those students will enter the public dental workforce, including Smile Squad. Just as one example, I'd like to talk to you about the program's secondary school model. The data told us that the consent rates for secondary students was much lower than they were for primary school students. This didn't come as a surprise, but we knew it needed to be addressed. Earlier this year, we collaborated with our community dental agencies, students and schools to assess our secondary school delivery model. We then engaged co-design experts to complete an intensive qualitative research project to look at the needs and opinions of young people when accessing Smile Squad services across Victoria. Collaboration occurred through a mix of secondary school students in Bendigo, Wangaratta and Preston in Melbourne. What we did was explored and validated reasons for not attending Smile Squad appointments, understand the perceptions around the program, map out the areas of tension or drop-off in engagement, and explore ways to improve service delivery specifically for people aged 12 to 19 attending secondary schools. The secondary students told us they had concerns about their privacy. They didn't necessarily want their friends and peers to know about them going to an appointment. They wanted to be communicated with differently, and they would like us to use social media to reach them. YouTube was reported as their channel of choice to research dental procedures and to answer the questions that they have. And they would also like to attend telehealth appointments or appointments outside of the school environment. So DHSB is currently working through this feedback and adapting its secondary school delivery model to provide an improved and more tailored service to the older students. The student is always at the centre of everything we do, and through consumer engagement and co-design, we better understand who we are providing services to and what they need us to deliver. We began developing Smile Squad nearly 5 years ago, and much has changed and developed in that time. In 2019, we launched the program statewide with a view that it wouldn't matter if a student was visiting an exam van in rural Victoria or a treatment van in central Melbourne. They would have a similar experience wherever they were. Our vision for Smile Squad is the delivery of consistent, accessible, high-quality dental care every time. Our vision remains unchanged, and we're proud of the consistent service and experience we continue to provide. Thank you.
Thanks very much, Melanie. I'm going to go now to Anna. Wendy, you can talk to us about the osteoarthritis chronic care program, please.
Sure. I'll just give you a really quick update. So osteoarthritis is the leading form of arthritis in the country, and the burden of disease is expected to increase substantially over the next 10 to 20 years, in part due to the aging population and the rates of obesity as well. So the whole premise of osteoarthritis is that we know that if it's untreated and managed early with conservative care, then the rates of hip and knee replacements, particularly for those two joints, which are the highest burden of involvement, increases. And it's a no-brainer that there's a significant cost to the community with the rates of hip and knees. And so they cost about $20,000 to $30,000 a year. There was some very good pilot data that was done by the ACI going back more than 10 years now, with the number of sites across New South Wales demonstrating that good quality multidisciplinary conservative care for patients with osteoarthritis of the hip and knee can delay or cause complete deferral of hip and knee replacement by up to 7 to 10%. And that was an obvious winner. So based on that modeling, which Deloitte did initially, so for the tertiary hospital that was involved with the modeling was Royal North Shore, that figures of $200,000 of investment, you would end up saving $1 million. So that was backed then as part of the initiative, and so that was then rolled out. So we set out the Concord OACCP and went to our executive with that model of care in 2017. And I guess the whole premise of that is having a good team. And this is very much medicine at its best with collaborative care. And it's a combination of medical staff who are clinicians, but medical staff who are also allied health professionals. So particularly with osteoarthritis, physiotherapy, dietetics are critical, but also other services like podiatry, occupational therapy, social work, and very importantly, psychology. There are huge impediments to for people to exercise and also to embark on weight loss. And particularly with the COVID era, that was another additional reason for why psychology was particularly important. And then our administrative staff in terms of having people who you could relate to. So it's a team-based approach. And the idea was that the patient would turn up after they were reviewed by the physiotherapy coordinator for each of the services, that when they were then coming back for their first multidisciplinary appointment, that you would then target which clinicians or allied health professionals each of these patients would have to see. So for patient A, it might be a physiotherapist and a dietitian and a psychologist, but patient B might need OT and physio and podiatry. But they would see all of them on the one day. So they wouldn't have to go to 5 different appointments, which would then decrease compliance and adherence. And this program would run across 12 months with quarterly reviews. And what we found at Concord was that we attained rates that were much higher than the ACI. And in fact, in the last 6 months alone, our rates of deferral for knee and hip was 14%, which is substantial, and it's a huge cost saving for the hospital, but also if you extrapolate that, it's to the taxpayer as well. So important lessons to be learned.
Thank you very much. Move to Shireen now. Shireen, can you tell us about the operations, the integrated care implementation of Plan Care for Better Health? Thank you.
Absolutely. I'm going to expand on a little bit more than Plan Care for Better Health because things have moved forward a little bit. So you can see my slides? Yeah, thank you. So firstly, what I'd like to do is, just touch on Jenny. So Jenny is a 31-year-old female. She's got multiple complex health and social needs. She's pregnant. She's got some mental health needs. She's got all of these different service providers linked in to her care. So I guess the thing that we're trying to point out is if to provide value for Jenny, all of this needs to have a more integrated and coordinated approach. So her care is not fragmented. If we look at the evolution of chronic disease management and integrated care over the past few years, this journey really started in 2009. And so I like to think that integrated care is really a journey of evolution, and it requires continuous improvement for us to provide value to the patient, the clinician, the system, and the population. So our integrated care journey started in 2009 with the Chronic Disease Management Program, was the first early attempts to really kind of integrate care. We then moved on to integrated care for people with chronic conditions, taking on the recommendations of the earlier program. Through that, we developed the 4 core elements process for supporting an individual through an integrated approach for care delivery. We then also, with Plan Care for Better Health, we used a risk of hospitalisation algorithm to identify people most at risk and link them into the appropriate service and care coordination to support their needs in community. And then at the moment, or where we're heading now, is maturing that delivery model to really look at an interdisciplinary approach for care delivery. And I guess also what you find is, because we're working at a state level, we're working with every one of the LHDs across the system to be able to have a more consistent approach for how we deliver care for people with complex health and social need in community. And so obviously, to be able to support operational implementation, you really need strong strategy and governance, and this is really informed by evidence. And you'll see that, you know, there's been lots of changes over many years. The integrated care strategy itself was really released in 2014, but it was really not, you know, it was not a new thing. Integration had been happening for a long time across New South Wales, and there are some exemplary models that have been around for quite a while. This was really about us moving forward. It was really about re-establishing our focus on you know, really taking a person-centered approach to how you provide care in community, and really work towards providing value for the patient, the clinician, the system and the population. In 2019, we had the next evolution of integrated care, which is really around collaborative commissioning. So pulling together regional partnerships between PHN and the ministry with some seed funding to support the development of a local community pathway. We had the value-based healthcare framework, patient-reported measures, and moving forward to the joint statement and the future health strategy. And, you know, you can see this evolution of change over a few years that gets us to where we are now. And it's this iterative process, right? It just takes, it does take a little while to get there. And so I think also, if we look back to where we started, you know, in our integrated care journey, we really took an innovative approach, provided funding to districts that had to apply for funding to deliver an innovative model. In 2018, there were 25 projects. And so we then had to apply a scaling methodology to determine which of those would be appropriate to take forward for scaling. We identified 6. And so we then, one of those 6 was the Emergency Department to Community Initiative, which focuses on people with, focuses on people who frequently present to emergency departments. We've now scaled that across the system as well. Planned Care for Better Health is also scaled across the system. We have, with collaborative commissioning, we have 6 pathways underway. They are cardiac in community. There's 3 COPD models, 1 diabetes model, and a frail and elderly model. This is really a partnership between the LHD and the PHN. It's a bottom-up approach to developing a community pathway in partnership with primary care. We've also, through, you know, the horrible years of COVID, there's been a lot of positive that has come out of that and growth. And I think, you know, the progress we've made in the virtual care space is quite phenomenal. We've also got lots of, you know, being able to support lots of people in rural communities with access to specialists through using virtual care. And especially now when we still continue to have lots of workforce issues as well. We're also reviewing our risk of hospitalisation algorithm. It's been implemented for about 1.5 years now. And so we always knew that with the initial development of the algorithm, which was all based on data, we had to put it into the field so it could be tested by clinicians. And with feedback, so we could then make the next iteration. And so we're in the process of, we've completed the next iteration. We just need to be able to get it up onto the system so it can be used. So it's a very exciting time. And also, you know, what was very lucky for me and my team, I guess, or I don't know if luck's the right word, but there was a functional review last year. And so we've pulled together integrated care, collaborative commissioning, and leading better value care under a single director. It's fantastic for the system because it is all focused on chronic disease. It really allows us to look at a full patient journey for anyone with chronic disease. And then we've also had virtual care team also aligned to our branch, which supports all of that operational implementation at a local level. There's also been, and I'm sure you heard, the new New South Wales urgent care system in development, which will have a single front door and 25 urgent care clinics across the state. And so really looking at how you better flow patients to the right service at the right time by the right provider, and really moving away from, you know, non-emergent care arriving at the emergency department door, essentially. And so this year we've also got, you know, a few big things underway. We've also been scaling the New South Wales ambulance paramedic to mental health line pathway, which will facilitate, again, patients getting to the right service at the right time. And this year we'll be focusing on developing some work in the paediatric space as well. And then just from an enablers perspective, I think these are obviously really key to supporting how you work. Patient Flow Portal, which has been the tool that we've used across our system for integrated care. We're actually now going to be opening that up so we have a single community care platform for each of the LHDs. It provides them visibility of all of their local programs or initiatives that they're implementing. They will also have some dashboards attached to them, so it'll give them real-time monitoring operational data. We also have our integrated care outcomes database, which we link data twice a year. We have the Lumos data system, which is the GP data linkage program, which is going to be increasing to 4 times a year. You know, so this gives you a really good visibility of how your patients flow across the system. We're also moving towards statewide health pathways. This is an initiative where we will fund the licensing of health pathways for the state and will facilitate the implementation of priority pathways that are consistent across all of our regions. And then eventually, and hopefully not too many years, we'll have the single digital patient record and the Epic system implemented, which will really give us a single electronic patient record across all of New South Wales, which will be phenomenal, and we can't wait. We're also moving to statewide virtual care platforms and remote patient monitoring. Yeah, so there's lots happening across New South Wales. Yeah, and that's it for me. Thank you.
Okay, thanks very much, Shireen. And I think that's a really good segue of going into George, listening to George, because New South Wales has been on the value-based health care journey for a long time. And so it would be really good to hear from you, George, about the agenda that you have in New South Wales Health.
Yeah, thanks, Deb, and very much building off everything that Shireen talked about. We're at that point in our journey, I think, where we've had the opportunity to reflect a little bit. As Shireen's slide shows, there was a range of programs that have been around for a number of years. Naturally, we had to sort of hold back a little bit on our implementation approach throughout the pandemic. And then the functional review that Shireen was talking about, which allowed us to think about which of those models that have been implemented for a while are at the point where they can become part of business as usual and can move into that streamlined management under Shireen, with a bit more of a focus on how it contributes to the district's overall performance. Obviously keeping that lens of outcomes and experiences, but considering it as part of one of those many models that help with patient flow and the challenges our hospitals are under. in that time as well, we've also launched our Future Health Strategy, which is the New South Wales 10-year strategy, which provides the vision for where we're going. And that gave us the opportunity to think about value-based healthcare and what it means to our staff and our people. And reflecting on the Future Health Strategy, aspects of value-based healthcare were very much embedded throughout. So what we're doing now is kind of supporting the districts through those programs that Shireen is leading, but then thinking about how we can make delivering better value part of business as usual for all staff. And I think some of the reflection and conversations we've had, which has been useful learnings for us, has been that whilst it was really important to have the programmatic approach, and that allows us to accelerate things, trial and pilot particular approaches, there have been some aspects of our health system that felt excluded, in that by referring to it as capital VBHC, for some staff, it implied you're either doing value-based healthcare or you're not, which we know is not the case. We know that everyone goes to work striving to deliver the best outcomes and experiences we can for patients. So our challenge now is how to embed it as I guess a set of principles, and then wrap around support to make value-based decisions and outcome-based decisions the norm, really removing some of those barriers that get in the way of what we know our staff want to do. So a couple of examples of that, and as Shireen's touched on them a little bit as well, is the work. We know that obviously to deliver value-based healthcare, it's about considering the whole patient journey, not just the episode of care. So the work with the primary health networks has been a big part of that, and Shireen highlighted the joint statement there and some of the working groups, really taking a one health system approach. The work of data linkage as well to be able to see that whole patient journey. We're also have developed some guides for our staff about how to establish and implement a local value-based healthcare like initiative. And I think it's fair to say that implementing initiative is just like normal clinical redesign that everyone's familiar with, but it applies that specific lens of, for us, the quadruple aim in New South Wales. So part of that process is demystifying and saying, actually, this isn't revolutionary, but it's about really being able to focus on the outputs and broaden your scope from, I guess, the narrow episode of care to look at all those interconnections. Another piece that we know has been raised in the past as a barrier to delivering the kind of care people aspire to are the funding models and purchasing frameworks that we have in Australia. That's not something we can tackle alone, but definitely through the Ministry of Health, working with the Commonwealth and other partners, we're piloting new innovative funding models through the collaborative commissioning program that Shireen talked about, as well as advocating for change. And I think that's going to be one of the fundamental roadblocks that we hope to chip away at. It's a challenging one. I think, as everyone on the call probably knows, there is no one-size-fits-all funding model that suits different areas, but I think there's a lot we can trial. How we put that into practice will be our challenge, but really for us, it's about evolving our language so it is not necessarily you have achieved value or you haven't achieved value as a binary concept. It is about how we can strive towards improved outcomes for both our patients and the system, and that's kind of part of the reflection of our language.
Thank you, George. I mean, I think that's a really interesting thing, the whole concept of value and people being included or not within the value-based healthcare game. And it's certainly, I know, even within institutions, let alone whole systems, if they get excluded, then that can be a really good disincentive for anyone implementing it in the future. So
Deb, you're on mute.
good point. Thank you. Sorry, you've missed me talking all that time. But I'll go straight. I'm actually going to go to questions now. And I particularly want to pick up on what George was talking about, the whole concept of value. But Gillian Skinner had a question for Anna in relation to when she spoke, you were talking about the substantial cost savings, but did you have any discussions in relation to the value for patients, please?
Sure, absolutely. Excellent question. So none of this is possible without the value for the patient. So the entire premise of the program is having the centre at the patient at the center of the journey, just as much as similar to Melanie's program. And one of the biggest barriers to care is when you've got very fragmented care delivery, and particularly when you're needing multiple allied health inputs that you might need in a condition like osteoarthritis. The patient's journey is augmented when you've got concentrated care delivery at one point in time, but also tailored to that individual patient. And so that's the entire premise of the OACCP, that the patient is initially assessed, and then a decision is made as to what are the needs of that patient in consultation with that patient. And then it's almost a curated program for that patient. In terms of data, what we've been collecting over the years is both PREMS and PROMs. So that's patient-related outcome measures and experience measures. And there's really good data to show that there's significant improvement in both objective and experience measures for the patient over the course of the 12-month period, and also when we follow them up after, regardless of whether they go on to have a hip or knee or come off the program, because they feel like they're valued and their needs are met. And even if they do end up, which is, if you flip the numbers around, the vast majority of patients still end up having surgery, more than 85%. But they feel engaged, they're more likely to be compliant with their therapy, and then continue on with those sort of better health decisions after they've had surgery as well, which helps them with the other joints, but also things like rehabilitation and length of stay. And one of the things that we're doing at the moment is validating a questionnaire that's been actually validated in the American population. So it's called the Promise 29, and we're doing that in the Australian population. And across SLHD, we've got 3 sites. So we've got the Institute of Musculoskeletal Health under the umbrella of SLHD. So what we're doing is collaborating across the 3 sites. We've got slightly different demographics in terms of the patients, but the data is still incredibly useful, and you've got much better data sets when we've got bigger numbers. So we're going to pull that data over the next 12 to 24 months.
Sounds good. The question of value has also been raised by Gillian to George and Shireen. I mean, obviously there's some fantastic work she's explained about too, but can you also talk about your measurement of value, particularly from a patient experience point of view?
Do you mind if I jump in first, Shireen, then I can throw to you for some more examples?
Yep. Absolutely.
Lovely. Yeah, definitely. I think in everything that we say and we communicate, at the heart of those is about the quadruple aim, that value-based healthcare can only be sort of achieved if we're striving for simultaneous improvements across that quadruple aim. So in addition to measuring the avoided costs in terms of bending the curve, we measure both patient-reported experience, patient-reported outcomes, and we're also trying to mature our approach to measuring the provider experience or clinician experience of delivering care. So in the early days, what that looked like was using our Bureau of Health Information, who have a long-established New South Wales patient survey program, and oversampling some of the patients that were cohorts in those statewide programs. And that was able to give us a baseline before we started implementation of what they reported their experience to be. And we're thrilled to say that on the whole, patient experience is improved a few percentage points across all of these programs. So that tells us obviously that we're not having an adverse impact on experience. In fact, it's improving their experience, particularly for metrics around their understanding of healthcare and sort of their ability to communicate with the clinicians. And I think the models of care, particularly when we've seen them shift from an inpatient setting formally to the new, more value-based models in the outpatient setting, that's also reflective of a better experience. And I think that's what we knew anecdotally. I think, you know, as good a health system as we can all have and the passion of our staff, no one wants to be in hospitals, and there are better ways of delivering care that deliver better sort of experience and outcomes, and that's been born in the data. We also measure patient-reported outcomes, and as Anna was saying, Promise 29 is one of those key generic quality of life tools. We also then have the condition-specific tools. Those have been really important, and I think, I'm trying to rack my brain, I think we've now had 30,000 individual patients record their PROMs in the HOPE platform, which is designed as really a point of care system to enable shared decision-making between the clinician and the patient. So the patient fills out their prompts before the consult with the clinician, and that forms the basis of a discussion, and then we track that over time. So we're seeing really beneficial use at an individual level. I think our challenge now is to improve our understanding and analysis of PROMs at an aggregate level. What does that tell us more broadly about a program? And I think that's a challenge sort of right across the world in terms of they're well embedded at a clinician patient level, but there's more we can do at a system level. So we've got different teams in the ministry and our pillar organizations looking at guidance for analysis. And then, as I mentioned as well, before we implement any of these programs that Shireen is leading, there's a baseline measure of the provider experience of delivering care, and there's some follow-ups on that to understand those aspects. And really for us, part of our approach is that triangulation of the data to talk about value as a whole from the quadruple aim perspective. We've flirted with ideas of, a value index, but that's still sort of in the idea space, and we haven't quite got there yet. But it's definitely something we're looking at. And along with our future health strategy, there's a measurement framework that sits beside that that's being developed. And for each of the 6 strategic outcomes in future health, which, as I said, sort of really pick up on the themes of value-based healthcare, we're looking at both leading and lagging indicators and looking at those key outcomes so we know, are we having an impact on what matters? And one of those objectives within our strategy is how can we make our metrics more patient-centered?
Actually, Shireen, do you mind if I just go to Melanie on this, this one too? I just want to check. Melanie, I know that you've done a lot of work in relation to measuring value, and you've had a lot of reflections over the time. What are the things that you've learned on that journey about measuring value?
Yeah, thanks, Deb. So I guess we are very much still on that journey. We do keep our, we do have outcome measures. So we have oral health questionnaire, and we're collecting all of that data. We've got a big, I think we've got about 50 or 60,000 with one, and we've got a much smaller number where we've got the second one, but we're starting to look at that. And I guess if I take sort of that example of the secondary school students, that's one of the areas where we're looking at, that value question, because we've got quite a big range. We've got all over the state, metro, regional, we've got 5-year-olds through to 18-year-olds. So value, it doesn't obviously mean the same thing to all of these people. Because of the scale of the program, we kind of went out with this one size fits all, and we're now adapting on what we're learning on what is value, and the examples I gave for the secondary students, value to them is something very different to value to little kids, or even value to the parents, so we are finding that that going into that very qualitative area has been a really good way for us to understand what that value equation means for our different groups.
Okay, thanks. So, very interesting thing. I mean, one of the things that that comes up all the time, and I think I mentioned at the beginning, is a lot of people go, "Where do I start?" And the really interesting things is you've all started. You're sort of early pioneers in this in Australia. So what would your advice be to people that are starting on the journey now about where it comes to implementing value-based healthcare? So Anna, do you want to start off?
Sure. So, I mean, one of the things that we did was look at the pilot data. So for someone starting now, it's to talk. So we did a lot of background research, trying to work out what's been done before, what worked, what didn't work, and then to try and model it to what your local needs are. And that requires a lot of due diligence. The other really important part is the local champion. So you need buy-in locally to try and show the benefit for whichever organization you're part of. But the critical part of all of this is none of this works without a really good team. So the right people, and cultures can be built, but you also need the right people with the right skill sets, who are meticulous, because you do want to collect this sort of. It's not just about doing a clinic, but it's about also collecting good quality data, as Gillian's questions are, and also as George and Shireen alluded to. So from the outset, we did, even before the first clinic opened, there was 3 months of just working out before the patient walks in the door, what are the data sets we're collecting with every part of it, including prems and proms, and then what are the follow-ups, getting the ways of collecting that data ready, whether it be REDCaps and then how does it get back into HOPE or ACI. So having all of that done in the background and all of that due diligence helps to then collect it in a seamless way. Otherwise, you've got lots of missing bits and then you don't really answer the questions you set out to answer. But along the way, I think it's that ability to also morph because the unknowns crop up and there are resources that you might need along the way that you haven't thought about. And so that the ability to kind of be adaptable is important as well. Okay,
Shireen, would you like to add in here? You have lots of experience in this space, I think.
Yeah, thank you, Deb. Good overview there, Anna. I would have just included the patient. For me, you know, what is the problem you're trying to solve? Always start with your patient, so that you know that you're implementing a change that is going to have a positive impact for them as well. Obviously understanding your landscape, your key stakeholders, your champions, and then the evidence as well for supporting what you're trying to do. And then so probably some PDSA cycles as well would work really well.
Okay. I mean, consumer engagement is always considered critical in value-based healthcare. What learnings have you learned, Shireen, in relation to getting consumers involved and actually influencing the agenda?
Yeah, look, I'm going to say that at the level where we hold meetings or leadership groups with our partners in LHDs and PHNs, at this stage, we still have not engaged consumers into those groups. We do really rely on the local teams to bring the consumer in, because we may have an overarching kind of a 4-step process for how you work, but there's a lot of context at a local level that's going to be completely different. And so often the patient's view comes in then. I do think that we can do it better from a state perspective. I think that there's opportunity for us to bring patients in to participate in those kind of senior conversations, you know, those system conversations. So I would hope that, you know, in the near future, we'll be able to do that as well.
Okay.
But very important, yeah.
Okay. Anna, do you want to talk a little bit about your consumer engagement and how you've used them in your project?
Sure. So a lot of our original data came from the work that ACI had already done, which was consumer-led to try and determine what were the needs for patients with osteoarthritis of the hip and the knee. But along the way, what we've had done is also have some qualitative work done with our registrars who are part of the clinic. So they've then done thematic analysis with focus groups of patients to try and ascertain whether what we're actually delivering is what they need. And so that's it's a sort of separate lens to the kind of formal prems and proms data that we collect along the way. But it's just to ensure, it's sort of, as I said, as we're delivering a service to make sure that it's actually meeting the needs of the patients who require that. So that's been a separate kind of study, if you like, or research angle to understand their ongoing needs, and that continues to morph. And you know, along the way, as I said, COVID's affected the way we've delivered care. You realize that you can actually deliver some things virtually as well, which is better for patients, particularly when they're older and they're relying on family members to bring them in for certain things. So they're just little examples of instances where their story or their experiences actually made a difference to how we might deliver certain aspects of care.
Yeah. Melanie, you've been on an amazing journey on bringing consumer voice in, particularly over those different age groups. Can you tell us a bit about what you've learned in that process?
Yeah, so DHSB's had a strong focus on consumer engagement over a long period of time. When we started this project, we started off with a workshop. So we had, you know, very young kids, primary, through sort of to older primary school. We had families, and we brought them in and said, what do you want from a school dental program? So we started with this really pie in the sky, like, you tell us what would you like to see? So we used some of the elements of that. We established a consumer network. So we have consumer networks in DHSB, but we established one specifically for Smile Squad. So we targeted parents of school-aged children. We got over 100 parents signing up. So we've been able to tap into them for some of the information that goes home to parents. So we've used them kind of quite specifically for, you're our target audience for this communication. What is it that you want to see and hear? Obviously, I've spoken about the secondary school students, and one of the other groups that's just getting up and running, the Department of Health have just established a refugee advisory network. So that's got quite broad representation, and they're going to help with advising into those specific refugee, asylum seeker groups, people of non-English speaking backgrounds, to be able to help, because we, being an outreach clinic, there's a lot of paperwork we need to try to reduce, but we do know that amount of paperwork can prevent the people that we really need to get to from actually accessing the service. So bringing them in and starting to hear from them is going to just add an extra element for us as well.
Okay, that sounds good. One of the things that's always really key in value-based healthcare is data and measuring whether you are getting value, however you want to do that. Maybe from George's perspective, do you want to give your learnings that you've learned from data collection, and what worked well, what didn't work well, what would you have wished you'd done differently if you'd got your chance again?
Oh gosh, data, I must admit, data is not my area of speciality, but I think what I've been able to observe is one of the challenges, and I think considerations that people need when starting out, back to sort of some of the earlier conversation. And that is, I guess, the tension there is in any system between what we collect for different purposes. So I think a lot of our health systems at the moment, most of the data that we would collect, say, from our local health districts, or you might collect in Victoria from providers or other areas, is more output focused, is more performance focused, and that naturally drives certain behaviours or approaches. When we're talking about reforms like value-based healthcare, where we start to talk outcomes, I think that's sometimes challenges people's thinking, and there's a natural tension between the short term and the operational priorities, which, let's be honest, that's what is front of mind for most people. And where I'm sitting right now in St Leonard's, I can see Royal North Shore Hospital across the road. Trying to talk about reforms and thinking about outcomes that will be difficult to measure for several years, that's hard to focus on when you've got, the challenges of running the system. So I would say a critical part of choosing the right data is going back to your program logics and thinking through it progressively, and having a mix of data. Having data wherever possible, where it can be used for multiple purposes. So again, one of those challenges is between what many clinicians might like to use for the collection of PROMs versus a tool that, say, our economic analysts would prefer to be able to analyze at a system level. That's sometimes a bit of a trade-off. So understanding the primary purpose. I'd say focus on consistent collection wherever possible. That makes your triangulation and linkage down the track much easier. And from that, we can see so many insights. So the Lumos program Shireen talked about has been exceptional at linking GP data and New South Wales Health data to draw insights. And our Bureau for Health Information was able to analyse patient experience scores and then readmission rates to highlight the linkages between a positive patient experience and then health system utilisation. So those are kind of a couple of the takeaways. For me as well, and as Shireen has spoken about previously, it's about being pragmatic with what data you can measure. So by all intents and purposes, have your long-term goals for outcome-based data, but don't let that get in the way of being able to give rapid data back to clinicians and teams on the ground. Because I think that's one of our learnings from our Leading Better Value Care program, is it probably took a little too long to start feeding data back to know whether things are heading in the right direction and working. And that's what really drives that continuous improvement. So I think it's having a planned and I guess a spectrum of data.
I mean, there's a lot of debate about whether to have lots of problems and lots of data or very, very small numbers. It'd be nice to know your view and maybe other people on the panel as to how you feel about that.
I can jump in quickly and then hand over to some of the others who are doing it in more a clinical program. I think that the part of that trade-off is between the extent to which you go for a very individual patient-centric perspective versus a system level. So I think when we speak to all our different clinical networks, there is that tension to have a different PROM tool used within each network because that tool is better for a particular reason for that cohort. The trade-off is then standardization and the ability to benchmark and compare across cohorts. I think it's a continuing discussion. What we've seen though is across our state, there are so many patient experience collections, and that's kind of a testament to how many people have embraced the value of patient experience and the importance of measuring it. But the downside is a survey burden on patients and a lack of potential utility from that data. So we're going on a bit of an exercise now to try and standardize and rationalize some of those collections. So that kind of gives a sense of, I guess, where the pendulum kind of sits for us. It is at a statewide level, minimizing the number of diverse collections we can have so we can maximize the value while still respecting the benefits of having some unique questions for different clinical cohorts.
Okay, thank you very much. Look, I've realised I've just checked the time and we're getting very close to the end. In fact, we are at the end of the questions. There are a lot of questions and we'd love to be able to answer a lot more. But that does bring us to the end of this particular webinar. So I'd like to thank all of our panellists very much for joining us today. Applications are now open for the 2023 Value-Based Healthcare Awards. And there are 4 award categories that you can apply for. The Telstra Health Innovation Award, which is awarded to the project that is significantly innovative, and this could be in the startup or early phases of development or an established project demonstrating results. There's also the Navigator Group Transformation Award. This is awarded for a project that has demonstrated successful engagement across teams, sectors, or disciplines for sustained improvements or scalability. There's the Transport Accident Commission Equity Award. It's awarded to a project that demonstrates results in reducing health inequities and improving outcomes for a priority population. And then there's a poster prize. All submissions will have the opportunity to be considered for the poster prize. The awards are designed to highlight the spectrum of value-based healthcare implementation exercise and can encompass project focused on improvements in a specific element of value-based healthcare, such as consumer engagement or measuring what matters, through to those exploring large-scale organisation-wide value-based healthcare change initiatives or systems. So initiatives at all stages of their value-based healthcare implementation journey are strongly encouraged to apply. And I think the important thing of looking at these is people that have been through the process and finalists or win these awards. It's a really good encouragement for the staff that are involved in it and a lot of the consumers as well. So it's worth making the application. So applicants are invited to make a submission in the form of a virtual poster, including a 250 to 350 word overview of their project on the Value-Based Healthcare Congress website. The Centre also hosts regular webinars on topics related to value-based healthcare, and our next webinar is Driving Value and Innovation, Learning Health Systems in Practice. And that will take place on Wednesday, the 30th of August at 4:30. And you can register on the AHHA website. And to find out more about all of our events and activities, please see the AHHA website and subscribe to receive our monthly newsletter. And I'd like to thank everybody for joining us, and particularly the panelists. We look forward to seeing you again at any of the upcoming events. Thank you very much.